The dural venous sinuses are intracranial venous channels that drain venous blood from the brain to the internal jugular vein. These venous channels are located between the layers of the cranial dura mater, and their walls are lined by endothelium. There are 6 paired and 4 unpaired dural venous sinuses. The straight sinus is an unpaired dural venous sinus. The straight sinus, or sinus rectus in Latin, is also known as the tentorial sinus. It lies within the dura mater along the superior surface of the tentorium cerebelli, where the perpendicular falx cerebri forms a junction with the midline of the tentorium cerebelli. The confluence of sinuses, shown in green, is formed by the confluence, or joining of the straight sinus, the superior sagittal sinus, and the occipital sinus.
Choroid plexus, which is shown here in red, which covers the floor of the lateral ventricle and the roof of the third ventricle. The CSF flows from the choroid plexus through the body and tail of the lateral ventricle and into the third ventricle via the intraventricular foramen. CSF then flows to the fourth ventricle via the cerebral aqueduct, exiting via the medial and lateral apertures. CSF exiting the lateral apertures flows to the pontine system on the ventral surface of the brainstem, while flow from the medial aperture enters the cerebellomedullary system. It then follows one of 2 paths. The first flows around the cerebellum, draining into the superior system, from where it flows to the interpeduncular system. The second path flows down the subdural space surrounding the spinal cord to the lumbar system. This is where fluid is taken from in a lumbar puncture. CSF then flows back up the spinal cord, and it joins the flows from the fourth ventricle and the superior system. From the ventral systems, CSF flows across the cortical surfaces in the subarachnoid space, draining into the superior sagittal sinus via the arachnoid granulations. It then flows down the posterior surface towards what is called the confluence of the sinuses, where it joins the venous blood flowing from subcortical regions via the straight sinus.
To your fulcrums and become aware of the relationship between the bones. The focus is on, right now, the classic flexion and extension, the faster rhythm that is created by deeper tidal forces. So what you are listening to in the CRI level are the expressions and motion of individual parts. Again, we're just kind of going over this, organizing around the midline. So perception is more about form and resistance as opposed to... Now, this is a great exercise, this particular hold, especially in this time in your incarnation on the journey here, to use this hold as a training technique to no different than hitting a tennis ball against a wall or a machine or any type of practice. You want to differentiate between thoracic breathing and the respiratory mechanism hold, which will allow you to listen very intently to the flexion and extension of the craniosacral system. It's a very, very tough technique in the beginning, so again, give yourself a break, but a wonderful tool for creating subtlety in your touch and in your listening skills, because obviously at this point, the lungs are expanding and contracting. And
Osteopathic cranial manipulative medicine, or OCMM, is a treatment modality. Associated structures include the frontal and parietal bones, which articulate with one another via the coronal suture. The paired frontal bones are separated by the metopic suture at birth, and the paired parietal bones are separated by the sagittal suture. The frontal bone articulates with the nasal, maxillary, zygomatic, lacrimal, ethmoid, and sphenoid bones, forming the roof of the orbital cavity. The paired parietal bones articulate with the occipital, temporal, sphenoid, and frontal bones, forming much of the superior and posterior aspects of the skull. Just deep to these, a thick, double-layered fibrous membrane that adheres to the internal surface of the skull. To begin, we will assess the frontal bone by draping our fingers over the bone. With fingers resting gently, the physician assesses for any tissue texture changes, asymmetry, restriction of motion, or tenderness, or TART. The first technique we will demonstrate is the frontal lift. With the patient lying supine, the physician sits at the head of the table, letting their forearms rest on the table. The physician contacts the lateral borders of the frontal bone with their thenar and hypothenar eminences, taking care with placement to ensure they are engaging the frontal bone only and not over other sutures or bones. The fingers may interlace, and a gentle medial pressure is then applied through the palms of the hands to disengage the frontal bones from their articulations with the parietal bones. The physician then lifts the frontal bones anteriorly and slightly superiorly and maintains this traction until a release is felt. The frontal bones are gently placed back to their original position and then reassessed for improvement in motion with PRM and improvement in somatic dysfunction findings. To assess the parietal bones, place your hands in the vault hold, letting the mid part of your palm gently rest over the parietal bones. Again, assess for TART and any motion restriction of the parietal bones in external and internal rotation. We will now demonstrate the parietal lift. This technique works via release of somatic dysfunction at sutures or dural attachments. With the patient and the physician in the same position, the physician places the finger pads of digits 1 through 4 on the inferior borders of the parietal bones bilaterally, just below the parietal eminences, taking care not to place fingers over the temporal bone, occiput, or other sutures. The thumbs will cross one over the other above the sagittal suture and not touching the patient's head. Gentle pressure is applied from the bottom thumb into the top thumb and the top thumb down into the bottom thumb to disengage the parietal bones from their articulations. The physician will then gently apply cephalad traction by leaning back. Traction may be emphasized with different fingers depending on where the restriction is most prominent. This traction is maintained until a release is felt. The physician then gently places the parietal bones back to their original position and reassesses for improvement in PRM and somatic dysfunction findings.
Roll them over, and you can see the sacrum here. And here's the coccyx, and I'm just going to place my hand like that and then have them do that. And from this position, just listen. Now, again, what you may feel and or may not, this is a learning process. Again, don't be hard on yourself. What you will feel is that the coccyx will raise up toward the ceiling, and that is the flexion stage, and you may experience a filling of the sacrum. And as that's happening, the fingers are actually being pushed, the top of your fingers that are pointing cephalad are being pushed more down into the table. As it empties the body, which articulates with L5, the fingers will come up toward the ceiling as the coccyx goes down toward your table in extension. Okay, and as with all the other holds that we've done up till this time, what I would like for you to do is just be in this position, enjoy the position, hold your hand as quietly as you can. Imagine that your hand is actually under the table, maybe even laying on the floor, or in the middle of the earth somewhere, China, whatever, but bring your mind away from where your hand is, and again, hold the whole person that you're palpating. Don't focus too intently on the sacrum itself. Imagine, for this image again, that you have a water bag and you're palpating from the middle of that water bag, but don't lose consciousness and a quality of attention that there is an entire body that you're palpating, and it's fluid by nature, and there's movement, estuary-like movements that are happening. And just sit and be conscious with your eyes open or closed, or preferably a combination of both, and just hold the field. And again, listen at this point for the craniorhythmic impulse. Later on in this DVD series, we'll be exploring the other two tides. But for now, I just want you to hold the sacrum within the larger field and enjoy. Okay, so the anterior aspect of the sphenoid bone rotates anterior and toward the feet, cauded, and around a transverse axis in flexion, and the greater wing subtly widen and move toward the feet. In relation to this, the occiput also rotates around a axis, which is transverse by nature, but it's going in the opposite direction. So the junction between them, is called the sphenobasilar joint, and it's moving upward, or cephalad. And again, all the other midline bones are rotating in the opposite direction. So in the inhalation phase, the inferior parts of the sphenoid are moving, and the occiput are moving closer together. And you can take a look at this right now, the graphic presentation. And this is called flexion. In the inhalation phase, the inferior aspects move apart, and this is called extension. So before we go any deeper into this, I would say, just for kicks, take the next 15 minutes or so, and with your hands on the thumbs on the greater wing of the sphenoid, using Becker's hold, and of course you can do Sutherland's hold for this, the greater vault hold. Just listen for about 15 minutes. And then come back to the tape. Or if you don't have an opportunity to come back because a client is coming in or somebody that you can practice on, just listen in your mind after looking at this graphic presentation that we're showing you here. Just sit very comfortably using the practitioner fulcrums that you've used many times now, and just allow holding a field. And I don't think it matters so much if it's the biosphere or the wide field, although I would suggest in the beginning, because of the subtlety and the sensitivity of this area, to hold a wide field. And you can even listen to this in the whole concept of primary respiration. If you'd like to, look at the other books that you have on anatomy and look at the other bones, you can, using the dura as your foundation, everything that's encapsulated or encompassed by dura is their primary respiration system, and you can listen to it in movement, but the center of that is the sphenobasilar joint, or anything else that works for you. But if you did nothing else for the next 15 minutes or the next few sessions that you get to practice this, just hold the sphenobasilar joint and the graphic presentation that we're showing you, and just hold that in your field and listen and wait and let the system come to you, and don't have any expectations, and just allow Again, as I've said many, many times before, probably some of you are like, oh no, not again, eyes are raised. Just allow this work to unfold before you, and let it deepen. And the more hours that you do this, the deeper your understanding. The more years, the deeper your understanding. The ahas come from this work. People have told me that, years after I've taught them something, they remember it, or they wrote it down, and they remember hearing me saying, and the aha comes from hours and hours of practice. So try that for just a little bit, and we'll come back to more of this phenobasal joint in just a moment. It includes the occiput, the parietals, the frontal bone, the temporal, the palatines, the ethmoid, the vomer, and the zygomatic bones. The occiput also articulates with 6 other bones, and these include the sphenoid, the parietal, the temporal bones, and the atlas. So it's as if, as the fluid is welling up, one of the images that I was given, I think works really, really well, is like a flower, like a lotus flower opening. And their flowers are expressing their movement fluidically, not in a mechanical sense, but very fluidically. And part of that fluidic observation is going to give you information about a particular bone and its needs, or at a sutural compression. And so the sphenobasal joint is it's like a sighting mechanism. It's like binoculars looking into the system with little crosshairs that you can get the center focus of widening from side to side in your hands, while it narrows front to back. And most of the paired bones are flaring a little bit at that movement. So the lateral aspects are flaring, and you'll feel the parietal bones in your hand widening. So play with that for a little bit, for 15 minutes or so, and then come back to the session. It's in these little pieces that you master and you observe and you witness that your skill will deepen and widen, just as if you were playing scales on a musical instrument, or even 3 bars of a lick, or where you've heard something or you're interpreting it on paper, and you just, man, that is a great little ditty. Let me play that over and over again until I have it wired. Same thing with this work. You really want to take the time and get the small pieces of it and play with those small pieces until you own them. So try that. Just listen to the skull. Listen to it as it widens laterally, but front to back. It's actually narrowing.